Everyone, thank you for joining us for our seminar today. I am Warren Kinghorn, co-director of the Theology, Medicine, and Culture Initiative, and it's my real pleasure to introduce as our seminar speaker today, Dr. Tonya Armstrong, someone whom I've known and respected for a long time. Dr. Armstrong is a native of Durham, North Carolina. She has a BA from Yale University, Master of Theological Studies from Duke Divinity School, and an MA and PhD in clinical psychology from UNC Chapel Hill. Dr. Armstrong is a licensed psychologist and the founder and director of Armstrong Center for Hope, an interdisciplinary group practice in Durham, providing psychological and spiritual wellness for all ages. And I think we'll hear more about her work in that respect today. For many years also, Dr. Armstrong was the Minister for Congregational Care and Counseling and leader of a mental health support ministry at Union Baptist Church in Durham. She also has long experience teaching at Duke Divinity School and also at Apex School of Theology. She's the author of a book that I would recommend to you titled Blossoming Hope, The Black Christian's Guide to Mental Health and Wellness, published in 2018. She's a past president of the North Carolina Psychological Association. She's also a trained musician and vocalist, and so she's a very busy person. And Dr. Armstrong, we're really pleased that you are willing to take time to be with us today. Thank you for presenting to us today on the topic, Infusing Hope Amid the Mental Health Crisis, Reflections from the Journey of a Psychology Spirituality Integrationist. Thank you very much for being with us.
Thank you so much, Dr. Kinghorn. Greetings to everyone. It's my pleasure to be here with you all today, particularly to be back in the suite where I did much of my work here on the faculty with pastoral care here in Duke Divinity School. I'm hoping that everyone can see my slides. And so I want to dive right in because I hope that we will have some time for some conversation as we continue along. I'm noticing that I will actually need to stop sharing for just a moment and to go back in again. Thank you for your patience. All right. There we are. So I'll dive right in. As you will see from our conversation today, much of my vocational calling is associated with hope. And I wanted to just briefly touch on some of my overlapping vocational identities. The fact that I am a licensed psychologist as well as a theologian and minister, those are very important parts of my identity. And yet there are some other aspects of who I am that have informed the type of work and specifically the type of ministry in which I continue to be engaged. So I did want to just mention those briefly. As I mentioned a moment ago, I served for 5 years here on the pastoral care faculty, and I had an opportunity to give leadership to the MDiv and SW dual degree program, and have been pleased to see the contributions that my students have been making into the local community and the world. I also helped with some of the initiatives of the Duke Institute on Care at the End of Life. In addition to that, I've had opportunities since then to serve on another seminary faculty in the counseling program. So you can see where a lot of that integration has been a fairly consistent thread running through this tapestry called life. I also wanted to mention as an author and a producer, that has been more of a relatively recent experience, having published many journal articles, but the first book was a new endeavor and an album experience is really how I describe it, a book album experience. So I'll talk about that a little bit more later. Also, as someone who started the Armstrong Center for Hope in 2010, it has been a pleasure to learn a lot more about entrepreneurship. As you've heard, I have some formal training in psychology, music, and theology, not business. So that has been an ongoing endeavor of learning and giving. I also come to you all today as someone who spent over a decade, really honing speaking skills as well as consultation, specifically leadership consultation. So all of those parts of who I am will certainly influence the way that I think about my theology of hope. I'd like to spend a few moments emphasizing what that looks like as we then explore how it has been exposed and reflected through the work that I've done. So, in my experience, hope is a persistent belief in our invisible yet God ordained preferred future. And what I mean by that is we know from Jeremiah 29:11 that God says he has plans to give us a hope and a future. And hope is that persistent belief in God's intention to bring that to pass. And yet, I also want to share this quote with you that informs my work from Reverend Dr. Pauli Murray. Hope is a song in a weary throat. So it's a song that we're singing even when we may get tired sometimes. Life circumstances can obscure our perceptions and experiences of a trustworthy God. And so some of the work that I do is specifically with persons who've lost hope, people who, in fact, may perceive rather significant hopelessness. And one of the roles I've taken on is helping to restore and infuse hope in the lives of the people with whom I work. It is also part of my theology of hope that mental health ministry places emphasis on God's transcendence as well as God's immanence. And it's very important in the work with persons who have mental health challenges that we be able to focus on both of those aspects of who our God is. And the immanence is something that is especially helpful for people who are broken. I'll refer to this again, but I do want to insert here that sometimes we have a really binary way of thinking about mental health and mental illness. And I want to remind us in my comments today that mental health, in my experience, is really on a spectrum, and that we're really talking about, at the end of the day, we're talking about all of us having to maximize our mental health and recognize that there's always space for us to continue to grow. And so as we're growing, wherever we may be currently, we want to continue to be aware of God's immanence. And out of my particular experience as an African-American female raised in a Baptist tradition, I'd like to comment that the cultural conception of God as waymaker, heart fixer, and mind regulator reflects our shared belief that God is deeply concerned about our mental health. Now, imagine that this conception transcends my particular experience. I think many of you all are familiar with these ways of viewing God and experiencing God. It's very important that these aspects of showing God's immanence are so important in the kind of work that I do. I also want to point out in my theology of hope that Jesus' intent to provide abundant life, as referenced in John 10:10, applies to the wholeness of who we are, mind and spirit and body and soul. And we want to be sure when we're working with people, and especially with people with mental health challenges, that we can minister to all of those aspects of who they are. And there are some particular ways that we have tools within mental health treatment to do that. It's important to note that care for the least of these, as referenced in Matthew 25:40, includes those of us with mental health challenges. So we know that if we read through the list of the least of these in the Gospels, we know that there are references to those who are hungry and naked and those who are abandoned. So I want us to put on our 21st century lenses to think about how that looks today, how that affects persons who are marginalized in some different ways, people who are oppressed with some of the more, if you will, contemporary challenges or contemporary manifestations, I should say, of that today. And mental health challenges do fall under that umbrella. I want to mention that in a theology of hope, and I certainly hope that this is not just my lens, but advocacy and inclusion are both godly attitudes to be adopted, certainly as encouraged by Micah 6 and 8, to act justly and to love mercy and to walk humbly with our God. But also, advocacy and inclusion are concrete skills that are to be practiced. So we want to look at how do we put feet on those? How do we make hope come alive in the lives of people who have experienced struggle and brokenness? You'll also notice in some of my comments today that part of my theology of hope is recognizing that mentorship, supervision, those are forms of discipleship. We're told to go and make disciples. So no, the Armstrong Center for Hope does not have a baptismal pool. However, it is important to note that in the work that I engage on several levels, that one day at a time, one meeting at a time, one conversation at a time, we are forming disciples that are able to give glory to God in the particular and concrete acts as well as our words. Finally, you will see that I'm very concerned and engaged in the proliferation of care. That proliferation involves mental health survivors, as well as clinicians, as well as community members, family members, and so forth. And so sometimes when we're focusing on the mental health crisis and those affected therein, we can be focused on just the individual, as we would call in traditional psychological theory, the identified patient. But I'm actually talking about a much broader way of viewing our human flourishing and blossoming. So I want to take just a moment to review some of the highlights of the mental health crisis. Ultimately, I want to be able to talk more about our response to the crisis, more so than the crisis itself, but just wanted to leave you all with some data that is very relevant to us geographically. So these are data taken from the KFF, formerly known as the Kaiser Family Foundation, on anxiety and depression symptoms in an adult sample from earlier here in 2023. And we can see that specifically we're looking at adults who had symptoms of anxiety or depression measured by the PHQ-2 or the GAD-2. In North Carolina, we see a prevalence of 24.9% as compared to a US figure of 32.3%. So that is actually a number that shows some increase from certainly pre-COVID times. If we look also at this area here, I'm sorry, let me go back. There we are. If we look at this data and looking at the suicide rate, we've got, sorry, I've got some information on my screen. All right. If we look at the suicide rate in adults again, then we can see from 2011 to 2021, over this 10-year period, that there has been an upward trend. And in the United States, it has been at 14.1 lives per 100,000 as compared to a North Carolina rate of 13.2. And so we do see that there's a decrease in those rates prior to COVID, and then an increase again in 2019. So that is a rate that we all want to be concerned about. And we know that suicidality is not always purely a reflection of mental health challenges, but we do know that there often are correlations therein. And then there we are. If we look at persons who had depressive disorder and also acknowledged having an unmet need for counseling or therapy, we see that that rate is 18.3% in our state as compared to a national rate of 28.2%. So that is of concern as well. It's one thing for us to suffer. It's another thing for us to suffer in a prolonged way because there are not enough resources available or enough access available, which I'll talk about a bit more in a moment. I also wanted to share some data from the North Carolina Youth Risk Behavior Survey. This is also data from 23. From this survey, we see that 43% of 17,000 high school students reported persistent feelings of sadness or hopelessness in the past year. That has increased from 28% a decade ago, and we can have many hypotheses about why that increase exists. But you can look here at the demographic breakdown of what that looks like, both in terms of gender, in terms of our race and ethnicity, and also in terms of gender identity. All right. I'll also comment for that number that 69% in the LGBTQ community is very troubling, but I also want to comment that for the first few years of data collection, they were not tracking transgender individuals, which is why that T is not a part of that number. You can also notice here that for students who were seriously considering suicide, 22.3% of the students in that survey reported this. And again, you can see the breakdown of the ethnicity as well as gender and gender identity. All of these are terribly high numbers that we would like to see reduced, numbers that show, particularly when it comes to suicidality and depression, that people are experiencing hopelessness. And one of the things that is most important to mental health professionals is figuring out how do we infuse hope. Hope in and of itself is just the beginning, but we do know that hope is an important ingredient. So another thing that is impactful to how adults as well as children and adolescents are experiencing quality of life has not only to do with frank symptoms of mental illness, but also has to do with social determinants of health. Those are the factors that affect health outcomes, thereby reflecting the quality of life and wellness of the individual. So Healthy Communities North Carolina has compiled data. They, in support by the North Carolina Institute of Medicine, as well as the North Carolina Department of Health and Human Services, have come up with a specific way to measure social determinants of health. Those include social and economic factors, physical environment, health behaviors, clinical care, and health outcomes. So they have further divisions of those 5 areas. But for our conversation today, I just want to bring to your attention about 5 of these areas that I think are most experienced in my work, and also ones that I believe we should have a shared concern. So probably one of the most persistent areas is that of poverty. And the Healthy Communities North Carolina group refers to poverty as living at or below 200% of the poverty line. That equates to about a salary or household income of $53,000 per family of 4. Now, the data that is shown here on this chart from Healthy Communities is actually looking at individuals below 100%. But if you look at the data by race and ethnicity, you can see that there are certainly some disparities in who's experiencing the greatest levels of poverty. In Durham overall, we're looking at 31.1% of the population. The state target for 2030 is actually 27% of the population. And as we can see, some of those numbers are higher, most pronouncedly in our Hispanic communities. All right. I also want to show you this area of unemployment. We see, if we look at unemployment by race and ethnicity, that we see, although in Durham, the overall rate of unemployment is 4.7% of the population, this chart shows us that for Black members of the population, that number is higher at 7.1%. And the target for the state of North Carolina is to have a 1.7 disparity ratio between white and other populations. And this definition of unemployment is including persons who are intentionally pursuing work. All right. I also want to speak for a moment, especially because the Armstrong Center for Hope does treat quite a few children and adolescents. I want to talk for a moment about data on adverse childhood experiences, or ACEs. You can see here a list of the criteria that one would meet in order to have an adverse childhood experience. And so for Durham, the data show that 23.6% of the population are having at least two of these experiences. The North Carolina state target for 2030 is 18%. And so in our experience, the Armstrong Center for Hope does collect data on ACEs as a part of our intake process. And I would say that the number 2 is actually probably a fairly modest number. I would say that many of our clients are actually experiencing many more than 2 ACEs. And you can just look at these experiences, such as home or community violence, and imagine the ways that those impact the development of the psyche and the person and their view of hope or lack thereof. I also want to acknowledge severe housing problems that are part of Durham and many other municipalities. In Durham, we're looking at 16.1% of the population overall that is having at least one of these housing problems, that is overcrowding, high housing costs, or a lack of adequate kitchen or plumbing facilities. Okay. Our target is 14%. Which I think we would agree is a high number, and yet would certainly be an improvement from where we are currently. If you are a bit of a data nerd like I am, I definitely encourage you to go to Healthy Communities and actually look at our county population by census tract. And you can actually see how these numbers differ based on those tracts and zip codes. Okay, one last area I'd like to talk about is the category of persons who are uninsured. So we're defining that as persons in the population who are under the age 65 without health insurance. In Durham, that number is currently 11.8% of the population, whereas our state goal is 8% of the population. And if you look at the figure, you can see just how disparate those numbers are in terms of the levels of insurance. So again, the highest level of uninsurance is amongst the Hispanic or Latinx population, but we also can see that there are areas that are above 20% for several of the other groups as well, American Indian or Alaskan Native, biracial groups as well. All right, so all of these data that I've been sharing are pointing to what the mental health crisis looks like and what kinds of factors exacerbate that crisis. But I want to take a moment and just talk about some aspects of how the care that we express at the level of the community can work to increase and infuse hope into the populations that are dealing with the mental health crises. And perhaps it goes without saying, but I'll be redundant in mentioning that when we're talking about individuals who are experiencing a mental health crisis, and sometimes we think of crisis as being acute, but we also know the veterans in this kind of work, we know that sometimes persons are extending and experiencing chronic levels of mental illness. And so we're talking about the ways that families and communities and churches are being impacted by those concerns. So one example of a community-based approach to addressing mental health comes from some of my work at the Ministry of Congregational Care and Counseling at Union Baptist Church here in Durham at the corner of Roxborough and Dowd. So this is a congregation that I have been affiliated with for the vast majority of my life. And this is some of the work that I'll be talking about is work that I was engaged in from 2000 to 2021. So on the left, you can see our beautiful structure. On the right is a picture of a Stephen Ministry commissioning that we did as a part of this ministry. But let me tell you more about the composition of the ministry. So in terms of the structure, we report to our pastor, Prince Rivers, also a Duke Divinity School alum. And Pastor Rivers has been with our congregation for, I believe, about 6 years now. But this ministry was actually instituted by his predecessor, Reverend Kenneth Ray Hammond. And so Reverend Hammond was careful to establish this as not a pastoral care ministry, but a congregational care and counseling ministry, because he wanted to be sure to equip and empower the laity to be able to play important roles in providing care as well as professionals. And so you can see that MC3 was comprised of licensed mental health professionals, Stephen Ministry, as well as grief support group facilitators. There also was another portion that we engaged in for a while that was connected to providing support to military veterans. And what we found was that geographically we were at a disadvantage, because even though there was a national program put in place, it was actually in our state, mostly based at Fort Bragg, now Fort Liberty. And we did not have access at that time. And that was pre-COVID, so we didn't realize the power of the virtual work that we now provide. But these are the three robust parts of the ministry. And what we provided in the context of the church. So we had 2 different offices that were available. And through those offices, we provided counseling and psychotherapy for individuals, couples, families, and groups. We provided consultation for the kinds of challenges that our members were having. Sometimes we would even receive calls from other churches or other geographical areas that were of a particular spiritual or faith-based nature. We also provided referrals for those services that we were not able to provide in the context of our church building, which included psychological and psychiatric evaluations, medication management, and also severe and persistent mental illness. But our staff was fairly well connected and networked to providers who could address those issues as well. So I just mentioned this briefly because for any out there who may be considering how the church can have an impact on connecting with persons with mental illness, these are some particular ways that we provided education. So again, we're not just speaking to the individuals and families who may have been in a mental illness crisis at the moment. We were looking at how do we equip the congregation as a whole with being able to recognize both the reality of mental illness, but also the resources that were available, because even if they were not in a crisis in the moment, when they did encounter a crisis, they would know how to turn to us from the ways that we provided education. We also manage quite a few collaborations with other ministries, as you imagine, in order for us to not only be able to be visible, but to be effective by delivering services. We needed to have other ministries to make referrals as well. So our diaconate ministry, for example, had teams that often would be in the trenches, if you will, with many of our family members and could make referrals to us, or our parish minister or our youth minister, and so forth. We also had a number of community connections, and in the 21 years that I was a part of this ministry, this was one of my favorite things to do, is connect with some of our other sister churches in the area. With some of these churches, we conducted Stephen Ministry trainings together. For those of you who may not be familiar with that, it's a 50-hour training that provides education on how the laity can provide emotional and spiritual wellness. And so with many of these churches, we partnered with them. In some cases, they may have had resources that they provided to us, but all of these are congregations with which we worked during my tenure. Also, Faith Connections on Mental Illness. Dr. Kinghorn and I have actually both had the opportunity to serve as speakers for this grassroots organization that really challenges in a positive way how churches, faith-based churches and faith-based communities rather, can really respond in a helpful and vibrant way to mental illness. So that's just one example of how we were able to be a presence in the community. And again, on the one hand, we were most available to the members of Union Baptist Church, but many times we also were able to forge partnerships with other groups. For example, Families Moving Forward, a shelter for women and children. We were even able to provide services there. In some cases, licensed professionals were providing care, in other cases, Stephen ministers. But in both cases, we are looking at how do we make community impact? How do we have ripples of hope going through the community as a result of the work that we do? I also want to talk for a moment about client-based care. So to be clear, this work at the Armstrong Center for Hope is ministry in every sense of how I experience it, as I experienced it at Union Baptist Church. So I think we all know to be suspect of the artificial dichotomy between sacred and secular, but just wanted to name that in some ways we had a large church that we were providing services to, or that I was able to direct services for. But in some ways, the client-based care provided by the Armstrong Center for Hope has further reach into the community. So this is a picture of some of our staff members. This was a picture almost exactly a year ago. We had our first retreat together since COVID. And since that time, we have had, of course, there were some people who were not there due to COVID concerns, and we've made a few more hires. So this is actually only about half of us right now. But at the Armstrong Center for Hope, you will see in our logo that we advertise psychological and spiritual wellness for all ages. So often we get questions about, well, what does that mean exactly? And so we take for granted that when people are coming to us, they have recognized that we are licensed mental health professionals. They can see our pictures and read our bios, and they can determine that we have been trained in psychological treatment. The spiritual wellness part is something that some people are not even aware of. So, they just saw us on their Blue Cross Blue Shield provider panel and reached out. Others are very intentionally seeking us out. Perhaps they've been referred by a church member or a pastor because they want to have a safe space to be able to process spiritual issues. So we are a practice that recognizes that people are across the board on that, and we accept our clients exactly where they come in. And for some who are not interested in any kind of spiritual integration, then that is absolutely fine as well. So the care that we provide to our clients includes the individual, couple, family, and group psychotherapy. We not only focus on symptom reduction, which is kind of the most acute need for someone coming in the door with a mental health crisis, but we also instruct in skills promotion, for example, emotion regulation or adaptive coping, communication enhancement, or self and communitarian care. And we are brave or foolish enough to believe that the work that we do is not just about the symptom reduction, but it's about transformation, and specifically transformation by the renewing of the mind. And for the clients who do request it, we certainly offer spiritually integrative care, but we leave the onus of what that looks like on the client. Some clients may request prayer, some may request some reference to scripture, others want to have a safe space to express church hurt and work through that, and so forth. In addition to psychotherapy, we provide psychological testing, often for people who may need a diagnosis of a learning disability or attention deficit hyperactivity disorder, perhaps a personality disorder, or other type of behavioral challenge. We do provide that testing. We have been for quite a while engaged in speaking, training, and consultation. And just helping other faith communities in particular is one area of consultation that I especially enjoy. You can probably tell as you're listening to my comments today that being able to help other churches and faith communities launch mental health ministries at whatever level from one end of the spectrum to the other is something that I'm particularly passionate about and would love to have further conversation with anyone about that. All right, so I very much see that part of infusing hope is not only making sure that the mentally ill person and their family members are okay. I want to make sure that persons who are employed or contracted with the Armstrong Center for Hope are also receiving care and receiving positive experiences of what it means to be human and to be a worker and also to be a person who has other aspects to their lives. So this is another picture of our gathering together at the retreat. So just to be able to offer jobs in the community is a part of that entrepreneurship that I talked about. And that is a part of advocacy and inclusion, helping people to find employment, to pay bills, but also to have purpose in what they do. And I'm pretty sure that even our administrative assistants fully recognize the good that they are doing when they're helping someone to come out of a mental health crisis and to blossom from there. So in addition to the employment and contracting opportunities, we offer community building. I am one of these old school types of employers who says we are going to meet twice a month. And we have standing appointments or standing meetings, I should say. And those have gone on since the inception of our practice in 2010. And we still meet twice a month. And when COVID came, we went virtual and we're still virtual with those meetings. But we meet for not only business and case consultation, but for connecting with each other, for being real and human. So for example, yesterday we had someone on Wednesday, rather, speaking about burnout, something that we all need to be paying attention to in order to be engaged in this ongoing challenge of the mental health crisis. Clinical supervision is provided for interns. We currently have 4 interns, and they all are required to have clinical supervision, as are our associate level providers. So there's quite a bit of clinical supervision that is provided. Also, professional development is so important. I belong to 2 different groups of practice owners, and so we get to share experiences and compare notes about how we're conducting our practices. And I know that it is a rare thing for persons to have intentional engagement with each other. It is not uncommon for someone to open a business and to have lots of offices and have a scheduler and get providers busy working, but not necessarily providers who are able to engage one another and to really have moments where they can be vulnerable with each other, that they can figure out how to escape a season of burnout, for example. So we're very invested in the development of our persons and not just for the business that they can generate. So in that vein, we provide case consultation. We pretty much have a period of that at the end of each of our meetings. For my interns in particular, we have a didactic reading that we do every year. And this year we are reading Spiritual Diversity and Psychotherapy, a new book put out by the APA. But we also have continuing training for our evaluators. So the persons who are doing testing, we've increased the amount of testing that we're doing, and we make sure that we are engaging best practices with that. Also research experience, not exactly something you would necessarily expect a practice to do, but I'll show you in a moment an example of some research that we recently published. So I also want to talk for a moment about clinician-based care. Wednesdays at the Well is a program that I instituted in 2012, and it's a therapist consultation group that is focused on the integration of spirituality and mental health practices. We started out in person for 90 minutes. Now we're down to 55 minutes and virtual, but the beauty of that is that we've been able to attract a much broader audience. We have a number of Canadian colleagues who also join us each month. So we meet once a month on fourth Wednesdays, with the exception noted there on the slide. We have dialogue. We talk about theoretical frameworks, case consultation, and reflection on what it means to be that kind of professional caregiver. So it's open to professionals and students in mental health disciplines, and there's no charge for participation. I'm not going to read all of these, but you can see from some of the topics here that it is fairly wide ranging. We like to make sure that we're having a balance of what kinds of concerns, especially spiritual concerns, that we may see in our clients, but we also make sure that we're taking care of ourselves. We're paying attention to issues around balance and establishing priority, avoiding burnout, recognizing the grief, especially that came with the pandemic. And so I engage persons from across the community to come and provide these presentations for us. And usually there's a balance of a presentation and dialogue that happens during those 55 minutes. So I spoke to the research a moment ago. This was an article that was published in Practice Innovations, which is a part of the American Psychological Association's Division 42 Independent Practice. And I was pleased to be able to engage by 3 interns at the time. We wrote about increasing mental health utilization in Black populations during COVID-19. But notice in the subtitle, we were focused on clarifying clinician responsibility. We can write a paper, another paper, about the responsibilities that clients bear. But I really wanted to be sure in this particular article, especially at the height of COVID-19, that we were really thinking about what is it that we as clinicians can do. And briefly, we wanted to say if we're really committed to increasing Black mental health utilization, then we're going to need to understand historical cultural mistrust, which is deep. We need to enhance the pipeline of Black psychologists and, frankly, other types of mental health professionals as well. We need to be able to integrate cultural adaptations into therapy. And this is primarily to a non-Black audience that these comments are being reviewed by. We're acknowledging the suicide crisis. And so in that paper, we actually spend some time talking about not just the brief numbers I shared with you earlier, but in particular, how the suicide crisis among Black children has greatly and exponentially increased over the last 10 years. We talk in that article about affirming the importance of religiosity and spirituality for Black populations. And that is not a monolith, but certainly something that needs to be explored with Black populations. And then prioritizing self-care is a part of what clinicians have to do to continue in this work. So I've just got a few more slides and we'll have some time for questions. This is about care through statewide and national advocacy. As Dr. Kinghorn mentioned in the introduction, I did serve as president-elect, president and immediate past president of the North Carolina Psychological Association. This is a picture of me with my executive committee at that time. The great Sally Cameron in the red jacket, who served our organization for 38 years as our executive director. And I'm pleased to say that her successor, Martha Turner Quest, has stepped in ably to do a great job as well. So I've been a member of NCPA since 1995. And so during that time, I've been a conference speaker. I have served on the insurance committee, now called the Advocacy and Practice Committee. So again, there's that word of advocacy. How are we actually creating opportunities for hope for the general population of people who often have unmet needs? So I cannot take any credit for this, but our insurance committee in previous iterations had advocated to make sure that the state health plan, for example, had a copay that was actually affordable. Because if you have insurance, but the copay is out of reach, then it's almost like not having insurance. And so the state health plan numbers actually came down for several years. The copay amounts came down as a result of some of our advocacy. Much more recently, I have been a part of the Medicaid work group, and that is a group that has met with Medicaid to let them know that in the state, there are approximately 29 psychologists across the state that are credentialed with Medicaid. That's not a high number. And there are multiple reasons, which I fully understand, for not being credentialed with Medicaid. But rather than throwing up our hands, we wanted to engage and say, well, how do we create, in so many words, how do we create more hope for people who have Medicaid and don't have anywhere that they can go to actually use their insurance, their Medicaid, or they have to wait 6, 8, 10, 12 months just to be seen, especially for a psychological evaluation. So that's some of the advocacy work that I've been engaged in. And then I was pleased after I stepped down from the presidency to engage in an initiative called the Leadership Formation Academy, which has been in concert with some of our leaders from the American Psychological Association to begin to identify in the state of North Carolina who are other psychologists who want to give back to not only their businesses, but to the broader community and create hope for our populations. So last but not least, I want to talk about how some of my recognition in this work has been that there are many, many people from all walks of life who will never, for various reasons, make it to my office. They won't see me, they won't see any of my associates, but there is still a message of hope for them. And so in 2008, I launched my first album, which is vocal music, gospel music, some of which was written, some of which was arranged, and it's called Choose Hope. And then in 2018, I released this book album experience, Blossoming Hope, the Black Christian Woman's Guide to Mental Health and Wellness. And the purpose of releasing those two together was to help people comprehend in a deeper way, the lay public in a very general way. This is what depression looks like. This is what having dementia might look like for your auntie or your grandmother. This is what it looks like to have a cannabis use disorder. So I give several vignettes, and then I talk about what it looks like to transform in mind, body, soul, and spirit across the book. And then the soothing songs and spoken word recordings are a combination of, again, my vocal music, but also meditations, the Jesus prayer is included there, and so forth. So these are ways to infuse hope to a population that, again, might otherwise not be attentive to what it means to expand one's mental health. And they are available on all the major outlets. Blossoming Hope in particular is available in print, ebook, and audiobook. So I want to leave you with this. From Romans 15, verse 13. May the God of hope fill you with all joy and peace as you trust in him, so that you may overflow with hope by the power of the Holy Spirit. I pray that the work that you also do will be infusing hope with the persons with whom you work.